Hello, this is a lecture on Chapter 27, Surgical Radiography from Merrill's Atlas. Did you catch the picture on the light box, you guys? Cute. Okay, the surgical team we're going to start off with and what it consists of. In the OR suite specifically, this doesn't include like the IR suite or your ERCP room or anything like that. The surgical team is numerous. There are plenty of people in each OR. Going to consist of a surgeon, an assistant, possibly a PA, a surgical technologist, an anesthesia provider. It could be an anesthesiologist or a nurse, a scrub nurse, a circulating nurse, and then various support staff. Okay, they're divided into two classifications. You'll need to know this: sterile and non-sterile members. Sterile team members all have to scrub in. Okay, very important if you're the radiographer that's going to be doing a case there, that you make sure your surgeons are putting their lead on before they scrub in. And they're usually good about it because they have their own lead that they carry around. Okay, sterile team members are going to be the surgeon, the surgical assistant, which can be the assistant to the surgeon. It's another surgeon or a resident, but it's somebody who can take over the surgery. Okay, they can assume the duties of the surgeon. A physician's assistant, which I really haven't heard of, but your book mentions it. A scrub nurse, specially trained RN, and a certified surgical technologist, a CST. And this is the person in charge of that OR room to maintain the field, make sure everybody is not going to run into each other, new people entering the room know where to go, things like that, so their sterile field is not compromised. Okay, non-sterile team members do not ever enter the sterile field. We are assistants to the sterile team. We, as radiographers, are part of the non-sterile team member of an OR suite. Okay. They the members include, they can consist of the anesthesia provider. So whoever's doing anesthesia, the nurse, anesthetist, or the anesthesiologist, they are not sterile team members. They are using a lot of equipment. They're maintaining integrity of the patient in the respiratory care. Okay, there is a circulating nurse that will be the assistant to the sterile team members in the room. Okay, other non-sterile team members are the radiographer, like we mentioned, and any technicians or sales reps, anything like that in the RR suite. Okay, the proper surgical attire, as you all know, is going to be any head covering that you need, including facial hair. If you have a beard, you're going to have to cover that up with a hood. You're going to need to wear a mask at all times. Preferably you have good gloves on at all times, and you have shoe covers on your shoes. I mentioned shoe covers just because everyone should be making sure that they do not contaminate any OR rooms. The floor is always considered contaminated, but you're bringing germs in from radiology, the ED, things like that. So you are coming from downstairs, usually in a hospital environment, to upstairs to surgery, and you're tracking in a lot of stuff, so cover your shoes up. And then make sure you don't wear those shoe covers into another OR, so dispose of them when you exit that OR. Okay, operating room attire is the scrubs that are provided to you. You need to change those every single day. New, clean scrubs every day. Street clothes are never to be worn in the OR. Even if they're covered up, you need to change out. Okay, so some of the attire, of course, are the supplied scrubs that they give you, and then they will give you masks, they will give you caps, they will give you gloves, they will give you gowns sometimes. Your shoe covers. Okay, gloves. You should always wear gloves. You should always have your badge on also under your lead in case somebody doesn't recognize you. And always, always you're going to be wearing your radiation film badge, even in the OR. Okay, personal hygiene, we talked about this in class. Very, very important. Also important that you do not present in the OR sick. Most of us know that you should never come to work when you are contagious, meaning you're running a fever. But a lot of us do because we'd prefer to be sent home than call in sick. On that note, the OR is no place to present sick with a fever, contagious, since people will have open wounds in there. Okay, you're compromising the integrity of the patient and the care from the hospital. So don't do that. Just be very diligent and conscious of good health and personal hygiene habits. Okay, the OR dance, they're talking about how everybody works together. You don't want to contaminate the sterile field. You don't want to bump into each other. You need to know what everybody's doing and anticipate each other's needs. Most importantly, as a radiographer, you are going to stay out of the way until you are called to do your duty, your job. Once you do that, you're out of there. Okay, image receptor handling in the sterile field. So if you do need to hand off your IR, you're going to be handing it off to a sterile recipient. They will have a sterile bag. You're going to simply put part of the IR into that sterile bag and let that sterile person grab it from you, okay? They'll cover it up, they'll place it. You might have to tell them where to place it. Once the exposure is done, you will get that IR with the cover back. If they will not need the cover, they will not need to take it out of the cover. You will be assuming that that IR is contaminated, the cover is contaminated. Okay, now even if it looks clean, you're going to assume it is contaminated. So once you get that IR out of there, you're going to dispose of the cover and the gloves that you touched the cover with. Feel free to put on new gloves to handle the IR again, and feel free to clean the IR, okay? That's recommended. Okay, enemies of the sterile field, we mentioned this in class. Lengthy or complex procedures. The longer that you're in an OR case, the higher the risk goes for contaminating your field, okay? Just so you know, the floor is always considered contaminated. You are never, ever, ever going to place anything on the floor and then pick it up and expect to use it in the OR, okay? Never, never, never. The equipment. Okay, so this is paramount for a good radiographer. You want to be a participating member of an OR team. And to do that, you need to do your job and do it well and efficiently. So you need to know your equipment. So it is recommended that you make time to go get trained on that equipment. You insist upon it. And if there is no time out of your busy schedule because everybody's so busy, please feel free to take breaks or whatever you need to go up there and check the equipment out before you're called upon to go up there and you don't know what you're doing. Okay, so you need to know your equipment. Okay, you should always, always clean your equipment. And this doesn't happen all the time like it should, so you need to really make an effort and be conscientious about keeping your equipment clean. It's best for the patients. Okay, radiation exposure, you're the professional in the room. Okay, so you're in charge of making sure that everybody, all your radiation protection practices that you have learned and know are to be followed and adhered to. Okay, you are the one that's going to make sure that everybody in the room is wearing lead. You're going to make sure that everybody is a safe distance away before you expose, etc. Okay? Distance is the number one safest thing you can do. The farther away from the beam, the better off you're going to be. Okay, radiation exposure. They are mentioning shielding patients' gonads and procedures performed on children, etc. In our experience, though, when the radiographer enters an OR room, the patient's already been positioned and draped, and there is really, really a very small, minuscule chance that you're going to be able to shield a patient that's under drapes, okay? Hopefully, though, in your experience, you can have sufficient individuals on the OR team trained that know, and their shields kept in OR for this purpose, so that when they're positioning the patient before the surgery even starts, after they've been anesthetized, you're going to want them to position shielding appropriately. Okay, radiation exposure minimum source to skin distance is 12 inches. We know that from radiation protection. And in fluoro, the source is always under the patient, so shielding should be placed between the source and the patient if shielding can be put in. Okay? Okay, next we have OR fluoroscopic procedures. Okay, the main procedures that they're going to be talking about in this chapter and that you're probably going to be seeing are the operative cholangiography, chest line placement, so central line placement, sometimes bronchoscopy, not so much anymore, C-spine surgery, lumbar spine surgery, hip and femur nailings. You'll also see prosthesis placement for hips, tibial nailings, humerus replacement and humerus nailings. You also might see brain surgery, not so sure, and femoral tibial arteriograms. Okay, so for the operative cholangiogram, the patient is usually placed supine. You can see the illustration on the top of the page there. Okay, centered, the C-arm is going to be centered above the right side of the abdomen because we're looking at the biliary tree for the liver. Okay, a true PA, so the C-arm may have to be angled or tilted to align to the patient's anatomy. Just remember, you're going to use your X-ray eyes. Okay, here's some pictures of a biliary tree system with contrast, and the surgeon's going to inject the contrast for you. Okay, an OR chest. This is where you're going to have PICC line plate, not PICC line, sorry. PICC lines are usually done downstairs in the X-ray suite. You're going to have central line placement, some port placements, things like that in the OR. Also regular chest surgery. You might have to go up and do some chest surgery with a C-arm, and because they want to see how the heart's functioning, or if they're placing something in a heart like a pacemaker, they're going to want to see where the leads are, things like that. So the patient is usually supine for chest OR, and you're always going to cover your C-arm with sterile covers. Well, not you, but your team is going to cover with sterile covers, okay? You're going to enter the sterile field perpendicular to the patient, and that's when you're called in by the surgeon to take some imaging. Just remember that everything needs to be draped, okay? We don't want to contaminate anything. They need to be ready for you. And for line placements, the C-arm is going to scan from the point of insertion to the catheter end. So they're going to want you to be able to move that central, the C-arm, move it centrally so that they can follow that radio-opaque lead on the catheter that they're inserting. Okay, and here's some of the structures that are shown in the C-arm pictures. Okay, this one has the heart, has the central line. The arrow shows the tip. Okay, this other one is showing. Okay, it looks like this other one is showing, well, we definitely see the clavicle and part of the upper ribs, but we don't see the end of our catheter, so it looks like they're going to be moving the C-arm around to see the tip. Okay, C-spine, you're going to be called to the OR to take some images for C-spine surgery, fusions, disc implants, things like that. The patient position is usually supine, although I've seen them the other way. So it's usually supine though. The chin will be elevated. The neck is flexed that way. They can go in anterior. They're not messing next to the spinal cord. You won't see any of that though because their head's going to be covered with the drape for the anesthesiologist. You're just going to go in there when they're ready to take some pictures to see what the hardware is looking like in there. So be prepared. You're going to cover your C-arm. You're going to enter the field perpendicular to the patient, of course, so you can get that right over the top of them. Okay, you're going to tilt the C-arm 15 degrees cephalad. You got to remember that their neck is in flexion. Okay, so you're going to compensate so that you can get a true AP. All right, and center beam over the C-spine. All right, the lateral projection, you're going to rotate your C-arm so that you can make a lateral C-spine projection. You're going to angle if needed. Okay, and then the structures shown in your C-spine image should be the effective area of the C-spine and the hardware. Now this image up here on the top right is one with a breathing tube still in place, and it looks like they are prone for this one because the surgical instruments are in the picture on the posterior part of the neck. Yikes. Okay, and the middle one, it looks like that has a big cage, and that fusion looks like it's 3, 4, 5, 6. Looks like 3 through 6 on that one. That's a big one. Okay, and then the one at the bottom left, it looks like 2, 3, 4, 5, 6, 7. So there are some C-spine fusions, AP and lateral pictures. Okay, lumbar spine. The patient position is usually prone, obvious reasons. However, there are always exceptions. They do anterior approaches. It helps them to separate the bodies of the vertebra if they're going to do a disc implant. Okay, and I know this from personal experience. That is the surgery that I had. So I did not have them do a posterior fusion. Instead, it was an anterior approach. And it was fabulous. Had no problems with that. But normally, they are going to be prone. They're going to lay, there is a table that they use for L-spine surgery and T-spine, and it's just so that they can flex the spine a little bit. There are arm boards so that the arms will be out of the field of view. And of course, you're not going to see all of that anyway. When you come into the room, the patient's already draped, covered, everything else. Okay, but most likely they will be prone. So just think accordingly. X-ray eyes so that your projections are correct. Okay, your C-arm position. For a PA projection, you're going to cover your C-arm with your drape. You're going to enter perpendicular to the patient as always. You're going to center the beam over the affected area. Be prepared to move that C-arm around to get in the right spot at first. And then once you do, if they're going to want more imaging, remember where you're at. Get some landmarks. See where your C-arm is positioned when it's correct and the surgeon's happy, and try to remember that, okay? So, because you're going to have to move that out of the way and bring it back in. Raise the C-arm to leave enough room for the surgeon to work. And that's just if you're going to leave the C-arm in the room for the surgeon, okay? Okay, this looks like it is lumbar spine hardware imaging. Not necessarily from surgery. This one on the left is AP and lateral pictures with the hardware. Looks like they're discectomy films. See the contrast in the disc spaces? That's not something normally done in surgery, but it definitely is possible. The one on the right, it looks like an inverted image of an L-spine surgery site. Okay, lumbar spine lateral. So C-arm position, lateral projection, you're going to rotate into the lateral position. You're going to need to raise or lower your C-arm to get the spine in the center of the monitor. Now remember, this is part of being a great radiographer in the OR, is you need to know how your equipment works. And C-arms can move up and down. They also can go in and out. They can pan left to right. They can pivot. They can arc, and they can tilt. Okay, so you as a radiographer are responsible for knowing all of those nuances of your C-arm. And that way, when the surgeon needs you to get a specific angle or just tries to communicate with you what kind of picture he wants to see, you're going to know how to get that image for him or her. Okay, and the images you see here are more lumbar spine images post-fusion, post-surgery. Okay, next we're going to talk about the hip. Now, once you get into the hips and femoral nailings and tibial nailings, these are really involved, messy surgeries. This is where the hammers and the chisels come out in OR. And so this is going to be something to see. And they're going to call you in there, first of all, to usually take a picture before they start. And then they're going to want you to take a picture when it has been reduced and in a good position if possible. And then next, they're going to put some hardware in there, and they're going to want to position with the hardware in there to make sure everything looks good before they wake the patient up. Okay, so you're going to be in a hip surgery several times usually. All right, and in this position, these patients are supine. They are on a certain brace for hip surgery. One will have the unaffected leg up out of the way. It'll have one of their arms up out of the way, and then it'll have the affected leg in a device where they can apply traction. Okay. Okay, the C-arm position for a hip, specifically for your hip, is going to be between the middle of the legs, because remember, you're going to have to get a lateral, which is just like the cross table lateral we do for hips. So that central ray is going to be in the middle of their legs, okay? The beam, of course, is going to be centered over the effective hip, and you're going to have to rotate to try to get a true lateral or true AP for your surgeon, okay? The structures shown are going to be your proximal femur and hip joint. So you're going to see the acetabulum, you're going to need to see your greater trochanter, because your surgeon's going to want to see true laterals and true APs, okay? All right, next we have femoral nailings, and this is where they go in and they fix fractures of the femur, okay? And you can fracture your femur in lots and lots of different ways. Some people fracture right up top in the proximal femur, right by the head or the neck. Other people fracture their femur distally down by the knee, okay? And depending on where that fracture is, will help them decide which way they're going to go in and fix that femur bone, okay? And if they decide to go in at the top near your hip joint, it is called an antegrade, and that is because antegrade just means in the direction of the blood flow. And that just means that they're going to make an incision up at the top by the greater trochanter, and they're going to knock that nail down inside that femur, down towards the knee. Okay? Okay, for a nailing, and this is a picture up at the top right of a patient who had an antegrade insertion for a femoral nailing. Okay, and this is a couple pictures here of how your C-arm placement would be. All right. Okay, and this is a picture of a femoral nailing in the retrograde. So this is going opposite of blood flow, so it's entering at the knee and fixing the distal femur from the knee and pounding that nail up through the canal all the way up towards your hip joint, okay? The C-arm is rotated under the table for the lateral. So either one of these is going to be same C-arm position so that you can see your anatomy, okay? Okay, next we are going to talk about tibial nailings, and it's the same thing. It's going to be a very involved process where they are fixating bones. They use traction. There is a lot. It is a messy surgery. Okay, the knee starts out flexed to allow access to the tibial tuberosity. Okay, C-arm position, you're going to come in and you're pretty much just going to try to take true AP and laterals of the tibia. Okay, you are going to try to match the angle of the leg that the surgeon has. And, you know, a lot of the times the surgeon's going to move the leg to try to get it in the right position. So you're just going to take your cues from your surgical team. Now keep in mind too, another reason that you're going to know your C-arm, like the back of your hand when you go to surgery, is there is that left to right motion on a C-arm called panning. And with leg work and arm work, the surgeon might want you to follow the leg down. So if that's the case, be prepared to do that. Okay, be prepared to use your C-arm pan motion, which is just going to go left to right. Okay. All right, tibial nailings. These are some pictures of tibial nailings. Okay, C-arm pictures in the middle and regular radiographs on the edges there. Okay, humerus. So the patient is going to be supine, or sometimes they're sitting up, and it's called a beach chair style, where they're sitting up a bit. And it all depends probably on the surgeon. I've only seen actual supine reclining like this. The injured arm is resting on a Mayo stand. Usually they have the whole patient shifted or tilted off of the OR table so that the shoulder is off of the table, because when they want you to come in and take radiographs or C-arm images, they want the entire humerus, including the shoulder joint. So they don't want that obstructed by the table. Okay, you're going to cover it, of course, with a sterile drape. You're going to enter the field parallel to or at a 45-degree angle to the patient. Okay, and that's just because their arm is out. So the patient is, from head to toe, their arm is now out of that field. So you're going to enter in perpendicular to their arm, okay? The surgeon's assistant will rotate the arm medial and flex the elbow 90 degrees. That's something that they do. You really won't see too much of that, okay? But you're going to rotate the C-arm to accommodate those angles. They want a true lateral MPA projection, okay? Center the beam on the humerus or wherever the surgeon tells you to. Here's some radiographs of humeral head surgery and a humeral nailing. And remember, they're going to want to see all of the hardware, so make sure you take some good radiographs and at least you see most of the bone, but all of the hardware, okay? Okay, the femoral and tibial arteriograms. These are going to mainly be in the IR suite. However, there are surgery centers that do these up in surgery, okay? Lower limb may be rotated to remove bony superimposition from the vessels, and the surgeon's going to do that, or your radiologist. Okay, the C-arm position, you're going to cover it with the drape. You're going to enter perpendicular to the patient like you always do. The leg is going to be in the center of the monitor. Turn your wheels horizontal. This is the pan motion again, so that you can go right or left and track down the leg to watch the contrast, to follow the contrast, okay? You also will use subtraction technique in arteriograms, okay? These images here already have, the lower images are subtracted, but they already have the bone removed, it looks like. The one up top is a regular arteriogram image. Okay, here is subtraction images with the bone. Bones of the leg are seen before the subtraction has taken them out. Okay? Okay, so mobile procedures. So these are in addition to the fluoro. Okay, so not necessarily using a C-arm. All right. So you're going to learn about the lateral projection of the C-spine, a T-spine, a lumbar spine, and extremity exams, okay? Cervical spines, the patient can be upright, supine, prone. The head could be in traction, okay? Chin can be elevated. The IR is going to be in a covered drape. It's always going to be lateral, so it's cross table. Okay, beam is horizontal and perpendicular to your IR. And if you have a grid, You're going to want to make sure that you're centered to your IR so you don't get cut off, okay? And here are some C-spine images. All right, here is your lumbar spine patient once again, but this time they don't need a C-arm, they just need some radiographs, okay? Surgeon will let you know what he wants you to do. Okay, and this is a picture of a radiographer with the tube over the patient. And this bottom picture is another tube the radiographer is placing the IR. Okay, here's some pictures. Okay, extremity exam. So this case here, this is this picture here has a radiographer doing a mobile of, mobile of a hand wrist, looks like. Notice that everything is draped for him, which is perfect, okay? So the patient position, of course, is going to vary. The surgeon will tell you what you're there for, okay? Just be ready for anything. You're just going to need to make sure you can change your technique, okay, accordingly. Use a holder if you need to, if possible, okay? And then everything else is, the field's going to be draped. The surgeon will usually mark or point to the center of the image that he wants you to be taking a picture of. And once again, try to remember you want all of the hardware. Okay, more extremity exams. The one on the top there is a fixation of the ankle. And then you have a shoulder replacement. And then this looks like a short nailing. And these pictures look like they were taken upside down, so they are hung upside down here. So that is a distal femur. Okay, clicker question. All of the following are sterile members of the OR team except the surgeon, the anesthesia provider, the scrub nurse, the physician's assistant. The answer is B, anesthesia provider. Remember, they are a non-sterile team member. They are at the head of the patient, taking care of respiratory duties, touching a lot of machines. Okay, next question. Where is the C-arm position during a hip surgery? Perpendicular to the end of the table, parallel to the end of the table, parallel to the side of the table, or between the patient's legs? Remember, for hips, this is the one that is between the patient's legs. The C-arm is going to be between the patient's legs. Remember, your central ray enters just like it does across table hip. Okay? What is the single most effective method of radiation protection during OR imaging procedures? Shorter exposure times, longer distance from the source, lead apron, or thyroid shield? And the answer is B. The most effective method, the most effective single method of radiation protection is distance. Okay, of course we want time, distance, and shielding, but distance is your number one. Okay, in the OR specifically. All right, and that's it for chapter 27. And you guys have a great weekend.